There's dissatisfaction and even frustration among patients and physicians with the state of primary care in the U.S. When we're thinking about the physicians, they're facing low managed care fees, they're facing increasing costs of running a practice, and that's inevitably leading them to spend less time with patients, see a lot of patients during the day, have patients wait very long times for appointments, and that obviously has the potential to deteriorate the level of care, hurt the quality, and lead to inadequate care. Patients have the same issue. They don't spend enough time with the physicians. Very little face time leads the physician to rely very heavily on referrals to specialists. And of course, waiting a long time for an appointment has its own problems. Your condition may deteriorate, you're delaying very necessary care, and at the end of the day, you actually might resort to going to the emergency room or suffer some other consequences. This is not going to get better because this issues with inadequate access to care and the fact that there's mismanagement of health condition is only going to get worse with aging population, with increasing chronic condition prevalence, and with insurance expansions. So with the shortage of primary care physicians we currently have in the U.S., we see regulators, we see policymakers, we see employers, and we see health plans looking for innovative ways to change the landscape of primary care. One of those innovations, probably the most notable one, is the patient-centered medical home, which we study in this particular research. And we're trying to see if the adoption of the patient-centered medical home model leads to a reduction in the reliance on emergency room services. Patient-centered medical home can be best described as a model of primary care centered on the patient. It's team-oriented. It relies on accessibility to care, care coordination, and the use of IT to provide better care and better outcome for patients. Most of the patient-centered medical homes in the U.S. are recognized by the National Committee for Quality Assurance, or short is NCQA. NCQA is a nonprofit committed to improving quality in primary care. In order to be NCQA recognized, the practices have to put in processes for scheduling appointments with patients, for communicating with patients, for organizing, documenting, and measuring clinical outcomes, for implementing evidence-based guidelines in their practices, and for organizing and tracking referrals. And there's a whole long list of other things that they need to put in place to receive this recognition. Every one of those standards, elements, and factors that are being reviewed is getting scored. And when you aggregate the score, there's a determination whether this whether this clinic becomes a patient-centered medical home or not. And not only that, it also determines whether the recognition receives a low level or a high level. So there's different levels of recognitions. If you're a patient-centered medical home recognized by the NCQA, you have access to financial incentives that are provided by health plans, by employers, and in kind of in the early days of patient-centered medical homes, which we study, also state and federal-sponsored pilot programs. We find that practices that went through this transition and became a patient-centered medical home, the practice itself becomes the home for the patient. They're not going anywhere. There's a team-based approach that provides a home for every need that the patient has. The practices that went through this transition have reduced the number of emergency room admissions for their patients by 5 to 8% if the patient had a chronic illness. If the patient did not have a chronic illness, there was absolutely no reduction. This is the primary finding. And then when we drill down and look at the different chronic conditions, we see that a lot of those benefits and the biggest reductions that we see happens for patients that have either hypertension or diabetes. In addition to that, a very interesting thing that we've looked at is what's the mechanism that leads to this reduction in ED admission. And one of the findings we see is that the reduction in ED admission is not very sensitive to the timing of the visit. And what does that mean is that the reductions in ED admissions are not coming necessarily from the fact that the patient-centered medical home is open for longer hours or that it has more accessibility, but actually from better management of chronic conditions. That basically means that even if you seek care in the emergency department on weekends, when most of those primary care clinics are closed, you would still have the same reduction, the same benefit. And that tells me that your chronic condition is under control and it's better managed. I believe what sets our research apart is its scale. We look at 460,000 patients over 4 years in 280 patient-centered medical homes. And this was never done before, not on this particular scale. 115,000 of those patients, we see them each and every year in our sample. And that allows us to do things that, again, were never done in the literature. So it's not just that we can see what happened to the patient population when a practice decides to switch to a patient-centered medical home, but we can see what happened to an individual patient when their practice switches to a patient-centered medical home and follow the patient and see if there is a different experience for that particular patient during that particular transition. Previous research is very mixed on this issue of the benefits of patient-centered medical homes. So we didn't really know what to expect. I see our findings as somewhat comforting because we see the effect where we expect to see it and we don't see it where we expect not to see it. Let me give you an example. Patients that don't have a chronic condition, we don't expect the patient-centered medical homes to have a big impact on ED admissions. The main reason why a person ends up in the emergency room where they don't have a chronic illness is things like trauma, a motor vehicle crash. There's nothing in the patient-centered medical home that makes you a better driver. They're not claiming to do that. On the other hand, if you have a chronic condition, a better management of that condition, using all the processes that NCQA puts in place in the practice can have an impact. And it's very comforting to see that 5 to 8% of admissions to the emergency room are being avoided. Now, we have a lot of research that documents that many of the visits to the emergency room can be prevented. It's either that the visit is legitimate, somebody has a problem, but if they had better management, that visit could have been avoidable. And we still have a lot of visits to the emergency room where the setting is wrong. You could have went to your primary care physicians or to another setting and received care. You didn't have to go to this high level of acuity type care. If the patient-centered medical home model is the poster child for innovation in primary care, the stepchild would be, at least judging from the lack of interest among researchers, would be a variety of retainer-based medicine models, also known as concierge medicine models, where the heart of those models, there is a monetary transfer from patients to their physician in the form of retainer fee, which averages about $150 per month. In return, the physician is able to reduce the size of their panel from what we said before, about 3,000 patients, to no more than 600. This allows the physician to spend more time with the patient, have extended visits, about half-an-hour visits. Make sure that patients can come in on the same day, so enhance accessibility to care. And then patient can call their physician, they can email their physicians, so the service aspects and the convenience aspects are enhanced. The retainer-based models stem from the same dissatisfaction and frustration that the patient-centered medical homes models stem from, but retainer-based models have not received much attention, not in the literature, and to some extent in the media, but not all that favorable attention. And you might ask yourself why. Well, there's two main reasons why. One, people view this as medicine for the rich. This a little bit ignores the fact that most people who receive services nowadays in those concierge practices and retainer-based medicine models are middle class. And $150 a month, we can debate that, but for a lot of people, this is considered to be affordable. The second, and probably the biggest criticism of retainer-based models is its sustainability. We have a fixed supply of physicians. If every physician downsizes their practice, we're just going to exacerbate the shortage of primary care physicians. This is a valid criticism, but it ignores a couple of things. One, many physicians, especially at a certain age in their life, contemplate retiring, contemplate maybe changing direction professionally, working for a pharmaceutical company or something like that. Instead, if they can go into these retainer-based models, it buys them a couple of more years where they can work in this field in a different pace. The second issue is that retainer-based models tend to make primary care more attractive to young doctors who are choosing which field of medicine they want to go into. And if we want to solve the shortage of primary care in the long run, we have to make primary care more attractive. And we see that happening on the ground. And the last point is that there's many models of retainer-based medicine that do not rely on major reductions in the panel size. Those models, typically called hybrid models, have a huge potential because they're both scalable and also because they tend to segment patients into those who value access to their physicians from those who see their physicians just for routine checkups and very basic care. I think in spirit, Obamacare fits very well with this trend of innovation in primary care. This innovation, when we look at patient-centered medical homes, places the patients in the center. And in a way, it transitioned us from a world in which physicians were paid based on volume to a world in which we're trying to shift and pay physicians based on value that they create for their patients. That's very much in the spirit. What else is in the spirit is the reliance on information technology, on cost containment, on finding ways to have other non-physicians in the clinic, part of this medical home, that will work at the top of their license, will engage in population management, will reach out to patients with chronic conditions, and will follow up and will try to improve care to reduce the burden of kind of downstream utilization that can happen when those breaks in continuity of care occurs. There's a couple of research projects already underway. The first stream deals with this heavily understudied retainer-based medicine models. This is coming through a partnership with one of the leading companies in the industry to study the real effects of patients who stay within a retainer-based framework and those who find themselves outside of that framework. What happens when you spend half an hour with the physician instead of 8 or 12 minutes? What happens to referrals? What happens to outcomes? What happens to your health? And what happens on the financial side in terms of health costs? On the other venue, the patient-centered medical homes, our partners at Independent Blue Cross and I have received a very unique data from NCQA, allowing us to look at all the individual scores on all standards, elements, and factors for those practices that we've studied in the research I've described today. This will allow us to look under the hood and at the very granular level of what is driving change and innovation in primary care, and allow us for the first time to understand the elements that are driving the various improvements in care, both in terms of outcomes and costs.